Hi, welcome everybody to Ask Us Anything and Growing Healthier program. This is the Facebook Live, sponsored by the CGH Health Foundation. I am your host today, Dr. Song from Urology. Dr. Bird is out, and I have our esteemed guest, Dr. LeMay from OB-GYN here to have a great discussion today, okay? Hello, Dr. LeMay. How are you today?
Hello. Good. Day's been good so far.
Okay, well, wonderful. Thank you for joining us today for this great discussion we're going to have about women's health. All right. Happy New Year, by the way.
Happy New Year to you.
Okay, so I have my first question for you today is, what types of gynecological surgeries are done at CGH and in the OR and in the office?
Okay. Well, the fun thing about gynecology is it's a diverse field. We get to do lots of different types of surgeries. In the office, we do biopsies of the cervix. We do a procedure called colposcopy, where we look at the cervix and take biopsies. When girls have abnormal colposcopies, we do a procedure called LEAP, and that procedure can safely be done in the office where we remove the abnormal cells with a hot wire. Hot wire, and that works out very nicely. We also do endometrial biopsies, so taking care of the vulva. Sometimes you can get what's called a Bartholin cyst, and we do a procedure where we insert a catheter into that. So we get to do a lot of procedures in the office. In the hospital, when we're evaluating the pelvis, we do laparoscopy. We also do open cases, exploratory surgeries of the pelvis, open or exploratory surgery and hysterectomies. When we're evaluating the uterus from below, we do a procedure called hysteroscopy, where we take basically it's like laparoscopy. We take a lighted tube and place that up through the vagina and up through the uterus, and then we can see the inside of the uterus. And we have instruments that we can remove polyps and fibroids or things that cause abnormal bleeding in that area. We also have a procedure called endometrial ablation, where we look in the uterus and then we place a instrument in there that is an electrical type grid that applies energy to the lining of the uterus and makes the lining go away to treat cases of abnormal bleeding. So that's kind of the wide range of surgery that we do here. That is done, basically everywhere that OB/GYN doctors do.
Yeah, that sounds like a great combination of office procedures as well as the operating room procedures. So women that can have treatment both in both places. So that sounds great. My next question here is, hysterectomies are very commonly associated. Obviously, it was the main surgery that we all know and hear about. So what type of hysterectomies are done here?
So hysterectomies that we do here are vaginal hysterectomies, where we take the uterus out by going up through the vagina. That's the go-to type of hysterectomy if it can be done. Indications that let us do that, there needs to be some relaxation of the pelvic ligaments in order to get the uterus down a little bit into the vagina to be able to do that. We also do laparoscopic assisted hysterectomies, where we use the laparoscope, place that into a small incision in the belly button, and then we place smaller instruments through incisions that we make down lower, usually 3 small incisions with that, and we loosen the uterus up, and then we complete the procedure by bringing it out through the vagina and then sewing the vagina up. Then we do abdominal hysterectomies, where we make incisions crossways, or sometimes we have to go up and down depending on what the indication for the hysterectomy is.
Wow. That is incredible, because like the times that I'm also in that region, we're like neighbors. I cannot believe you can do all of that through the vagina. That is incredible that you can take the whole uterus out there. Okay, so I don't speak from personal experience, but so how about our next question here is, so the hysterectomy, we're focusing on the uterus. Now, the two ovaries, what are some diagnoses that require you to remove the ovaries as well?
So let's talk about a couple indications for hysterectomy first. Indications for hysterectomy are obviously cancer. There are tumors that grow in the uterus that are benign that lots of women have, called fibroids, and that in women that we can't treat medically or hysteroscopically, then sometimes need to have hysterectomy for symptomatic fibroids. Mm-hmm. There's a condition called endometriosis that we may get to later on to talk about that is causes women to have hysterectomies. We talked about lack of support and vaginal hysterectomies. That's another indication for that. Prolapse, where the pelvic organs start to fall through the vagina, and we can do hysterectomy and fix the vaginal walls, both the top and the bottom, called cystocele and rectocele. In situations where we can't control bleeding in the office with medications or other procedures, then abnormal uterine bleeding sometimes has to be treated with hysterectomy, as well as cases of chronic pelvic pain that can't be resolved by other means. Mm-hmm. As far as when do we remove the ovary, once again, we remove ovaries if they're cancerous, or endometriosis can get on the ovaries, and that could be an indication for that. Most commonly here, we remove ovaries for benign, non-cancerous growths, either ovarian cysts that won't go away or benign types of tumors of the ovaries. Mm-hmm. Sometimes you can get an ovarian cyst and the ovary can twist, what's called ovarian torsion, and that a few times a year becomes an indication for that. Also, when we're doing surgery for some reason that we do a hysterectomy in a menopausal woman, since the ovaries have quit functioning, we usually go ahead and take the ovaries at that time. And some types of breast cancer that are very estrogen driven in women that are not menopausal, will take the ovaries to help reduce the estrogen in a woman's body that has had breast cancer and treated that way. Wow,
that is a wide range of indications. It's a very patient specific. So thank you very much. Now so if a woman had to decide, this is part of taking the ovaries out, and there was an option, what are some of the advantages of keeping your ovaries intact?
So we always try to preserve the ovaries because they produce estrogen hormone, and estrogen is important in the female, especially for the, it keeps the vagina lubricated. It also keeps the bladder functioning, the transitional cells that make the bladder be able to accept more urine. It helps line that and the urethra. It just keeps the tissues nice and keeps you from going through hot flushes and the menopause.
Wow. I'm just listening to you, and I hear there's a lot of homologs with the testicle too. So anyways, The next question we have then is, does the age of the patient have an impact on a total abdominal hysterectomy versus a total abdominal hysterectomy with bilateral salpingo oophorectomy?
So that's good. Yeah. So if we're doing, I think that if you're doing a hysterectomy and the patient is menopausal and the ovaries basically have quit functioning, since they can become diseased as you go on through life, then usually we take the ovaries at that time. We also take them at the time, around the time of menopause. The time of menopause is about age 53, 53 and a half now. So someone that's 51 or 52, we have a discussion about, is it worthwhile to leave the ovaries for another year of function, or should we take them at the time that we're doing the ultrasound? So a lot of personal preference by the patient and weigh the risk and benefits, like a lot of things in medicine.
Wow. Yes. Okay. That sounds very good. Now, the question we have is, you've mentioned that fewer hysterectomies are being done now than previous years. You must have mentioned this previously. And then what other procedures are allowing this to be the case?
So since I've been in practice, we're able to treat a lot of abnormal uterine bleeding that comes because the menstrual period is irregular. We can treat with oral contraceptives. We can give progesterone to sometimes stop the periods. We can also, there's a device called a Mirena intrauterine device. It's a small piece of plastic that has that's shaped like a T, that has a progesterone insert on it, and we could put that in the uterus, and that will slowly be absorbed into the uterine lining and will stop the lining from growing in a lot of women, and thus will decrease the amount of abnormal bleeding they're having, and then a lot of times will stop their period. There's also, we talked about endometrial ablation, where we can go in as an outpatient, and we do it as an outpatient because it's probably just a little bit too painful to try and do in the office. But use a small amount of anesthesia, and we go in and place the device in there and cauterize the lining of the uterus, and it's 80% effective in women that are in, I would say, in their perimenopausal period, age 40s and up to menopause, where it will stop the bleeding, or at least make the bleeding at a point where it's acceptable.
Wow.
Also, one of the things when I started, there are a lot of women that have polyps or fibroids that grow in the lining of the uterus, and now with hysteroscopy, we can take the lighted tube, look inside the uterus, and we have a device or devices that we can go in and remove the fibroids or remove the polyps, and do that as an outpatient also, so that they don't have to have the more invasive hysterectomy.
Oh, wow. It sounds like you have a big set of spectrum of options before you have to get to this hysterectomy.
Right.
It's very good. And then my next question is, well, actually, you already answered this. There are what are the medications that are also helpful in reducing the number of hysterectomies or other gynecological procedures? You did mention that.
So we can treat with oral contraceptives if someone can take it. Obviously, women that are over 35 and smoke or have other health issues can't do that. Okay. For fibroids, there's a new medication out there called aromatase inhibitor, and there's a medication called Myfembree, and it's been out probably just in the last year, and we've got some gals going on that, women that have big symptomatic fibroids or fibroids that cause them to bleed too much, and the medication has been shown to be pretty effective with minimal side effects. So we kind of use our old-time contraceptive medications and devices to help decrease the bleeding, and then also some new medications that are now on the market.
Wow, sounds good. All right, we're doing great here. Okay. What effect does a total abdominal hysterectomy have on a woman's sexual functioning? Also with the bilateral self-ingo oophorectomy.
So that's a good question. That question can be answered a lot of different ways. I think we're all taught to say that if you have a hysterectomy, you basically are removing the uterus and the cervix that is partially in the vagina, and then you sew the vagina up. So in women that don't have significant prolapse, where the support is all good, I don't think that should have much of an effect on sexuality. It's the ovaries that have the effect, because once you remove the ovaries, then you decrease the amount of estrogen, and thus the vagina is not lubricated as well, and you enter menopause then and have hot flashes. And so it's the ovaries that tend to can affect sexuality, removal of them. Obviously, that women go through that when they go through the menopause, and thus some women need estrogen replacement.
Okay.
By taking out the uterus, I don't think it affects it that much.
Okay. Well, that's good to know about the hormonal difference and just the like this the mechanical removal of the uterus is not related to sexual functioning. Okay. What is your approach to patients having irregular bleeding who are going through menopause?
So in women that are going through the menopause, that are in that age range, that have irregular bleeding, and women that are menopausal and then start having bleeding, it's important that we sample the inside of the uterus. So a lot of women think when we do a pap smear that we do that, but a pap smear actually just samples the cervix, where we need to get up inside of the uterus. And we can do that in a couple different ways. We can do it in the office by using a small plastic tube, and call that an endometrial biopsy. And then depending on if there's a lot of thickness in the uterus and we think there might be fibroids or polyps in the uterus, then we would want to go and sample or go up in there hysteroscopically and do that in the hospital, where we can use the instruments to remove the polyps or the fibroids. And we need to do that in women that are having real irregular bleeding around the time of menopause or after they're menopausal, which means the definition of menopause is no period for 1 year. We call that postmenopausal bleeding, and about 20% of women that have postmenopausal bleeding will have either significant precancerous cells in their uterus or cancer cells in the uterus. So that's why it's important that if you have bleeding after menopause, you need to have that done.
Yes. Well, yes, that sounds concerning. So we definitely want to follow up with that one. All right, so the irregular bleeding through menopause, we certainly want to get that checked out. Now, if they've already gone through menopause, very similar answer. You certainly want to get that checked. So we'll go to our next question. What are your thoughts on patients taking female hormones as they go through menopause?
So I've always thought it's a good thing in women that don't have significant health risks, and maybe we'll talk about later for that. When I started practicing back in our medical school in the late 70s and early 80s, estrogen was probably, I think it was the most prescribed medication going. Then different studies and different things, estrogen has gotten kind of a black eye, and then it cycled where not a lot of women took it, and then a lot of women started taking it again through the, I would say, the late 80s and 90s, and now a lot of women don't take it. And the reasons for that is that there have been some situations that have shown increased risk of endometrial cancer in women that take estrogen just by itself. So in those women, we cycle it with add a progesterone, or what's called the SERM, which is actually used in women that have had breast cancer. Can't be taken in women with stroke or they've had a DVT. There's been some indications that it can increase the risk of in women with cardiovascular disease, myocardial infarctions can increase that risk. And certainly women with breast cancer recommend that you don't take it. But in a lot of women, it's very safe to take. Women that have had a hysterectomy can take just an estrogen by itself. Either there's a patch that can be worn. You can take it by mouth. In women that can't really take it or just have symptoms of vaginal dryness or painful intercourse due to vaginal dryness, can use estrogen cream. And we found that estrogen cream can be given safely in low dose, used daily or 3 times a week or so with a very small amount of estrogen can help resolve those problems. And we don't think that gets absorbed into the bloodstream and thus doesn't cause a problem with those other things that we talked about. So I think that estrogen is a great drug. Probably the biggest thing that I've seen recently is that menopausal women that are on Medicare, that a lot of the supplement insurance don't cover the medication, and it ends up being very expensive.
Yeah. That's always a roadblock to our medication treatment.
Right.
We have our first question from Donna McGlone. Yay! Would you like to take that question, Dr. LeMay?
Sure.
Oh, in general, what advice do you have for septuagenarians? Maybe in regards to women's health or estrogen or hormonal supplements or lifestyle, maybe?
Say the first thing again.
Well, it's a very general, so you could take it wherever you want, the question, but what advice do you have for septuagenarians? Women that are maybe postmenopausal, probably about 20 years. Maybe they're still sexually active, or maybe they probably have very active, physical lives. They may or may not have had a hysterectomy. Any general advice for female wellness? Oh, it's 1 second. You were muted for a second, but you're on.
Okay, if it's mainly the problem is vaginal dryness. As we talked about estrogen, I think vaginal estrogen can be used in just about everybody in a small dose. There's also a medication called Interosa, which is a DHEA derivative that once it's placed in the vagina nightly, it's like a small little wax medication, and it helps with vaginal dryness. It looks like estrogen to the vagina, so that increases the blood flow and increases the lubrication. Vaginal lubricants can be used with relations, and also sometimes natural products such as coconut oil or vegetable oil can be very good lubricants. And sometimes with dryness or irritation of the vulva, using the coconut oil on a small amount on a regular basis and rub that into the labia can help with those hormone type problems.
Thank you very much. Thank you. Susie, very good. This has been a wonderful talk. I am learning a lot here too. So our next question is, what is the role for vaginal Premarin cream? And we did discuss this, but Premarin cream is, if you want to say that again.
Yeah, so estrogen vaginal cream once again will help the urinary system. It will also increase the blood supply and increase lubrication to the vagina, and can make. I mean, it's actually indication. If you read on the box, is for moderate to severe vaginal pain with intercourse.
Mm-hmm. The Premarin and estrace. We were talking about cost. Sometimes these medications are not covered by insurance very well, so we do want to find different options. So Premarin or estrace, and then maybe even a compound pharmacy. So anyway,
eventually broken down into the same product. So whatever's can get the best deal on is the way to go.
Yeah. And then, okay, what are the risks for a woman taking female hormones?
Well, as I said, basically women that have had a history of endometrial cancer or have a history of deep vein thrombosis, we think estrogen increases clotting. So women that have had deep vein thrombosis or myocardial infarction or heart attack, or that have breast cancer, shouldn't take it. And it can, in women that, well, let me say with breast cancer, I think that it probably is safe in a small amount, as we think that it stays, given Premarin vaginal cream, that it stays just in the vagina, but that would be something that you'd want to talk to your breast surgeon about going on that, especially since there can be all different types of receptors and some more types of breast cancer sensitive to estrogen. And should take that medication if you had a history of stroke or a myocardial infarction. And if you have an acute blood clot going on, you shouldn't take it at that time. So I kind of mix that up. You talked about oral estrogen; those things more apply. Premarin vaginal cream can probably be used safely. If all parties know, the breast surgeon and the gynecologist, and figure out the right amount of medication that would just stay working locally in the vagina and not have a systemic effect or effect go into the bloodstream and affect the breast cancer.
Okay. Yeah, that's it. I think that's a very important distinction for us to make, and for women to also know, because vaginal estrogen is not treated similarly like oral estrogen. But we're getting good. So here, what is endometriosis? You briefly just discussed that.
Okay, as we talked about, endometriosis can be an indication for hysterectomy or laparoscopic removal. But hysterectomy or endometriosis is a disorder where the tissue that lines the uterus somehow gets out into the pelvis. We think that most commonly it occurs by women that when they have a menstrual period, that they obviously the blood comes out through the cervix and into the vagina, but we also know that it goes backwards or retrograde and goes out into the pelvis. And I think everyone has that when we do laparoscopic surgery with someone that's on their menstrual period. We see blood in there, but not everyone has endometriosis. So it's probably has a lot to do with genetics. Obviously, if you have the wrong genetics and that endometrial tissue goes out the fallopian tubes and into your abdomen, then that's when we see endometriosis. And what it does is it implants onto whatever is around there, the intestine, the ovaries, the front and back of the uterus, the fallopian tubes, and then that will cause chronic pain with intercourse, pain with ovulation. And we think what happens is that sets up shop on those areas. And then just like when you go through the menstrual cycle and that tissue is released out the vagina, you go through those same changes in these little implants.
Wow.
And endometriosis you can have a very small amount and have a lot of pain. And sometimes we see women that we operate on for some other reason, and we go in and it's like there's been glue poured into the pelvis, and have lots of endometriosis and have had no pain. So it's a very I don't think we really know everything about it. There are women that have bleeding from their lungs, some that have endometriosis in their lungs, and they have that when they're on their period. And it's a kind of a mysterious disease, but most of the time it's probably caused from retrograde menstruation in the woman with the wrong genetic makeup, and then it sets up shop and can cause pain with intercourse.
Wow, it's like another area of like a little bit of a mystery. Sometimes, like, yeah, with pain, it's very hard to pinpoint. So, okay, and I have my final question for you then. In your opinion, what would you say has changed the most in gynecological surgery or gynecology since you started practicing?
Well, I would say the best. I mean, the best thing since I've been doing this now for 40 years is the instrumentation has made our surgeries easier. Our laparoscopic equipment, which we have the very best available at CGH Medical Center, we have has made a big difference.
Mm-hmm.
The instruments that we use in laparoscopy have changed a lot. I think the biggest thing that I see is that we have an energy source called ligature that is we can place that on the tissue that we would usually cut. We would usually clamp, cut, and tie. Mm-hmm. Now we can place that on the tissue, and it cauterizes the tissue, and then we can cut it, and we can use that on blood vessels that are pretty big. Mm-hmm. It keeps the tissue from getting folded over like it would be in a stitch, and I think it makes things more comfortable, and it's added a lot of safety to our procedures. So I think the instrumentation is the main thing. Obviously, anesthesia's gotten better, but the equipment just seems to have gotten much better, and much better for using laparoscopically, and microinvasive surgery has gotten much improved.
Yeah, that's fascinating. Like, if you think about your training and what was available, and then now what you have in practice, I'm sure. So that's amazing that technology can help us so much. So Dr. LeMay, thank you so much for your time and your 40 years of experience and expertise. We really appreciate all the work that you do here, all the babies you've delivered, including one of mine, and all the help that you've been giving women all these years. So, and thank you for all the support that you've given the Department of Surgery.
Well, it's been fun.
Yeah. So, so that wraps up our interview today. Okay. And I have a couple announcements before I go. All right. I hope you enjoyed that talk. That was really wonderful. I learned so much. We are having a February blood drive, February 2nd. Blood is always needed, and it is an amazing gift that people give to other people. So please think about donating blood. And our next, and also donating Cozy Community CGH Operation Coat, Hat, and Mitten Drive. It's cold, but I'm sure it's going to even get colder. So if you have any extra coats, hats, or mittens, you can certainly donate them to the CGH Main Clinic, Lynn Boulevard Clinic, Dixon, Morrison, Walnut, and the Sterling YMCA until the end of February. So I'm sure other people would appreciate that if they need it. Wonderful. The last announcement is Dr. Singh, our amazing interventional cardiologist, is going to be interviewed. And that will also be on February 2nd, the same day as the blood drive. So she will talk about interventional cardiology, the heart of the matter, which is very appropriate for February. So I can't wait to see her interview. I'm sure we will learn a lot from her. And she has been doing amazing here. So, so everyone have a wonderful month until next time, and be safe and enjoy.